Okay, hey guys. So today we're going to discuss chapter 35 real quick, the sensory and neurological disorders. A lot of this we already kind of talked about whenever we were talking about chapter 21 and the congenital defects. So if you have any questions or you can't really remember that, go back to that chapter and reread some of those things. So, basically, starting out, the brain and the spinal cord are formed in early gestation from the neural plate, which evolves into the neural groove and neural folds by the third week of gestation. This is why it's so important that we have early prenatal care, as well as making sure that those moms are taking their prenatal vitamins. Any insult, critical event, insufficient folic acid, tetragenic exposure, infection, substance abuse, or trauma during this period of time can result in central nervous system malformation. And 1/3 of all congenital birth defects are neurological in nature, and about 90% of these are going to be the neurotube defects, which is the spina bifida, the encephalopathy. Like I said, go back, look at those. If you have questions about spina bifida or hydrocephalus, those are covered in chapter 21. Otitis media is an inflammation of the middle ear. It's often accompanied by infection. You'll often see this as a very, very common childhood illness. They usually don't have to come into the hospital for it unless it's severe. Just in case they do, ROM in pediatrics is right otitis media, not rupture of membranes like in obstetrics or range of motion up on the orthopedic floor, just so you know. For children, eustachian tubes are a lot shorter and wider. They kind of have a weird angle, and so a lot of times those nasopharyngeal secretions are going to be able to enter that middle ear more easily and cause these infections, and that's why you see this more commonly in children than you do adults. And you can see a picture of that on 753. Just notice the angle of the eustachian tubes. It occurs more frequently in boys and those children who attend daycare centers, if you have allergies or children exposed to tobacco smoke, and even those who use pacifiers. It seems to kind of change the dynamics of that soft palate and raise it a little bit, which allows for those microorganisms to be released from the nasopharynx. The exact cause is unknown, but causative organism is usually Streptococcus or Haemophilus influenza. Typically they do occur after a respiratory infection as well. Acute otitis media, the children will have acute onset ear pain, marked redness of the tympanic membrane, the middle ear infusion, and so we'll be looking inside their ear with the light, and we'll be able to just see this kind of redness, this infusion fluid on the ear. It's recurrent acute otitis media indicates repetitive infections. If they've had 3 in 6 months or 4 in 12 months, typically we're going to have to do some kind of grander treatment, maybe placing tubes in their ears, which is the meningitis, which you can read all about on 760. But basically that is just allowing drainage on that tympanic membrane. If you have a child who is complaining of severe pain and all of a sudden it's released in instant pain, that's actually not a good sign. That probably means that they have ruptured their tympanic membrane and they need to be taken to the emergency room immediately. Recommendations for treatment: if it hasn't ruptured or anything, we will put them on antibiotics, and like we said, if there's recurrent infections, then usually we have to go ahead and do surgery. Family teaching tips, you'll find that on page 761. Be sure to look that up. That's always good material for testing. So know what you're supposed to do with bottles and babies. Never prop a bottle, right? Reye Syndrome, actually, it rhymes with I. Reye Syndrome, it's acute encephalopathy characterized by cerebral edema and fatty degeneration of the liver and other abdominal organs. So anytime we see liver involvement, we're automatically going to think in our head it might affect the liver enzymes, right? So yes, it does. Liver enzymes, ammonia, PT, all elevated from poor liver function. A lot of times with these patients, you'll see that they are hypoglycemic. It usually develops after a viral illness, such as varicella or influenza. That's pretty important. And so basically, they had a viral illness. They were treated with aspirin. It is associated with aspirin use. And then symptoms typically develop 3 to 5 days after this initial illness. So you won't see it right off whenever they're still ill. It'll typically kind of waver out a little bit, and you'll see it about 3 to 5 days after this illness. The child starts recovering. The symptoms of severe vomiting, irritability, lethargic, and confusion all develop suddenly, and that's our sign. So follows a viral illness associated with use of aspirin, and usually they're recovering from that illness when all of a sudden they have severe vomiting, irritability, lethargy, and confusion. Immediate intervention is recommended. Mortality rates are high due to the cerebral edema, so that's swelling on the brain, with increased intracranial pressure and possible respiratory arrest. So they will be in an ICU setting for this due to just the rapid progression of this disease. There are stages of Reye syndrome. Stage 1 includes the vomiting, lethargic, and all their neurological signs are intact. But as you progress down and as it kind of goes further down, you'll see that neurologically they start having more severe signs and symptoms. So stage 2, they're very combative, that stupor, inappropriate language, sluggish pupils, localizes to pain. 3, coma, decorticate rigidity, sluggish pupils. Stage 4, coma with brainstem dysfunction, decebrate rigidity, and loss of corneal reflex. And then 5 is coma with seizures and loss of deep tendon reflexes and respiratory distress. So you can just see the progression of their central nervous system, how it goes, becomes much more deeply involved the further they go. The goal of medical management is going to be providing supportive treatment to prevent any kind of secondary effects of cerebral edema and metabolic injury. The nursing care focuses on monitoring the child's physical condition, providing emotional support, and teaching parents about disease prevention. We're going to check the child's respiratory and neurological status frequently. Every 2 hours, we want to be checking on that status. Okay, neurologically, every 2 hours, check that status. Monitor lab results, INOs, administer fluids, electrolytes, and medications as ordered. With hydrocephalus, I'm not going to get into this because we've already talked about it in chapter 21, excuse me. But it is that imbalance between the production and absorption of central cerebral spinal fluid. Okay, so you remember shunting, a shunt. There we go. A shunt is what allows that cerebral spinal fluid to go on down. It usually is going to be in the stomach. They allow a little bit of extra space for growth as that child grows. They have that coiled tubing in the stomach so it can grow with the baby. But this is what hydrocephalus will look like. Remember those sun-setting eyes? Neurotube defects, spina bifida, most common neurotube defect. It can occur anywhere along that spine. Let's see. Remember about care of the child. We want to do surgery quickly. Whenever they first come out, you're going to do sterile water to that sac, protect that sac. They will be proned, and you want to make sure that they're not completely paralyzed or immobile on their hips and feet. Bowel and bladder sphincters could be affected, so we're checking this as well. Yeah, go back and read chapter 21 if you have any questions on that. For seizure disorders, the most common seizures in pediatric patients are going to be those febrile seizures. So if parents come in and they are telling you that their child had a seizure, one of the first questions you want to ask them is going to be what? Yes, has the child had any fever lately? So febrile seizures, most common in children between the ages of 6 months and 3 years. It usually occurs in the form of a generalized seizure early on in the course of the fever, commonly associated with high fevers, 102 to 106. You can read all about the nursing process, page 762 through 763. Highly recommend that. But what are you trying to do? What do you need to do for that child? You have to protect that child during seizure, prevent aspiration, injury, provide any kind of anti-seizure medication. And if it's febrile seizures, that child's usually not going to have any kind of seizure medication. Simply controlling the fever with the Tylenol, ibuprofen, going back and forth between the two is going to be your treatment of care. O2 suction equipment in the room, make sure it's connected, right? And throughout your book, you see there's several announcements, several things talking about seizures. I know you've had this already in med-surg, and that's why I'm not going to go all into it, but I do want you to look over partial seizures, generalized seizures, absence seizures, excuse me, and just kind of family teaching tips, precautions before, during seizures, page 766. Sorry, there's lots of nursing care tips there, so make sure you touch on all of that and look over it. Okay, meningitis. You will see meningitis on the pediatrics floor. A lot of times these babies come in, and yes, they are babies. It's seen most frequently in 6 to 12-month-old babies. Usually don't see it before 2 months, and you really don't see it after 4 years of age, but you'll see these babies come in, and one of the first treatments, or one of the first things we do to these babies to get a diagnosis, is going to be a lumbar puncture. So you ever see these tiny babies getting a lumbar puncture, usually it's to rule out meningitis, bacterial meningitis at that. So this influenza type B was the most common cause of meningitis in children prior to the use of the HIP vaccine, but we have a vaccine now, and so it's really helped decrease this. A lot of times what you're going to see, these parents who come in have not vaccinated their children, and so that's why we're doing the lumbar puncture on them and trying to get a diagnosis. It can occur secondary to other infections such as otitis media, sinusitis, pharyngitis, cellulitis, pneumonia, septic arthritis, head trauma, or a neurosurgical procedure. And so they have already been sick, they're coming in, and usually this is the reason why. With meningitis, basically white blood cells are accumulating and covering the brain with a purulent exudate. The brain becomes edematous and the ventricles become blocked, which impede the flow of central spinal fluid, just like in hydrocephalus, and so this can cause hydrocephalus. They are on droplet precautions, so not just contact, but it is spread droplet, and we will start a heavy dose of IV antibiotics. Cerebral palsy. This is a disorder of movement and posture resulting from a non-progressive abnormality of immature brain occurring in the prenatal, perinatal, or postnatal period. So typically this happens sometimes during pregnancy or right after pregnancy, during delivery, and it occurs because of a anoxic event. Basically, that baby did not get enough oxygen to the brain, and CP is the result of that. It is the most common chronic disorder of childhood. Its motor dysfunction is related to the location of the brain insult. So wherever that brain did not get enough oxygen, that is what's gonna, that part of the brain is what affects the body that is affected. Hope that makes sense. Where the brain got injured, it affects the injury of the body. So sometimes you can see it very, very severe. Other times you would not even know that this child has CP unless they told you. Prenatal causes, insufficient nutrients, oxygen, all can cause damage to the brain of the developing fetus. The risk for CP also increases when intrauterine infection, like chorioamnionitis. Talked about how infection in those those fetal tissues can occur. Tetragenic factors, drinking, eating, doing something that you're not supposed to, exposing the child to tetragens, and then nutritional defects as well can cause this. As I said, sometimes it's severe, whoops, and then other times you would just never even know. Premature infants are at higher risk because of immature central nervous system, and so the longer that child is in utero, the better chances that they will not suffer with this. The rate of CP increases with decreasing gestational age, and other causes can include cord prolapse, which of course is going to cut out the circulation to that baby, meconium aspiration, they're not able to breathe in and get enough oxygen, and then intracranial bleeding and anoxia. So no reduction in CP has occurred since implementation of electronic fetal monitoring, which is kind of a surprising fact because we feel like we can monitor those babies better, but it still hasn't decreased the effects any. Postnatal causes is usually going to be neonatal sepsis and hyperbilirubinemia. So we definitely want to get those kids checked out and make sure that they are not jaundiced. Head trauma as well. It's characterized by abnormal muscle tone and lack of coordination with spasticity. So symptoms depend on the area of the brain involved and the degree of the anoxia. How long was that baby without oxygen? Frequently have language delay, speech impediment, seizures, and often mental retardation. Children will demonstrate abnormal positioning and developmental delays. They do require physical therapy, speech therapy, and special education classes. And like I said, some have CP and it only creeps up whenever they're extremely tired or fatigued, and you would never know. And then others, it's as bad as all of that, the mental retardation, seizures, and lots of different delays, growth and developmental delays as well. Medical intervention includes anticonvulsants, skeletal muscle relaxants, histamine antagonists to prevent GI side effects. With your nursing, you're going to carefully screen growth and development. You're going to provide adequate nutrition, maintain skin integrity. With that spasticity, they don't always have control over their arms or limbs, so we also have to watch for skin breakdown with them. We will promote safety and growth and development, foster parental knowledge, and provide emotional support. On page 771 and 770, you'll see different casts, different tools that they can use with these children. The cast on 771 is often what you'll see if they're able to walk at all. Some are wheelchair bound, some children are, but if they're able to walk at all, a lot of times they will have these AFO braces, just like that one, and it just helps support that foot. With head injuries, a lot of times parents get very scared about head injuries, and of course that's understandable. The significant cause of serious injury or death in children of all ages. Toddlers and young children may receive a head injury from a fall or from child abuse. School-age children, adolescents usually experience such an injury as a result of bicycling, inline skating, or motor vehicle accidents. So we kind of have to watch and really monitor the stories, make sure that there isn't any foul play, any kind of child abuse that we're worried about there. With the treatment, if it's bleeding, caregiver can apply an ice pack and pressure until the bleeding is controlled. Without bleeding, the caregiver may apply ice for an hour or so to just decrease that amount of swelling. An open wound should be cleaned with soap and water and sterile dressing applied, and then observe that child for at least 6 hours for vomiting or change in the child's level of consciousness. If that child falls asleep, we want to be waking them up every 1 to 2 hours, making sure that their level of consciousness has not changed, that they are able to wake up. No analgesic sedatives at this time because we are trying to observe them and make sure that they aren't going to fall asleep or go into a coma. The child's pupils are checked for reaction to light every 4 hours for 48 hours. And then we want to notify the healthcare provider immediately if the child vomits more than 3 times, pupillary changes, double vision, blurred vision, is acting strange, confused, trouble walking, has a headache that becomes more severe or wakes them from his or her sleep. And sometimes, we'll have children go into they'll have head injuries, comas, and they'll just start acting weird, and the only thing that comes up is maybe a level of consciousness or behavioral change, and so that can be real freaky to the parents. One story was that this kid was playing football on Friday night. He got a really bad hit, and it was about his 3rd time he has had a head injury. He got up, he shook it off, no one thought anything about it, but then the next day, his parents can't find him anywhere. They're trying to locate him, and he finally, when it all comes down to it, he said he was running away. Typically not this child's type of behavior at all. Well, it turns out that that was really the only injury that he was showing from this head injury. So we do have to watch him very, very closely for that. You see a lot of times where they'll get a big goose egg on their head, and it looks a whole lot worse than, it looks bad, but at least with it going out, it's better than going in. So complications of head injuries with or without skull fractures can include cerebral hemorrhage, cerebral edema, and increased intracranial pressure. So we're always watching to make sure that we're not seeing any kind of signs of increased ICP. Drowning is the second leading cause of accidental death in children. Toddlers and older adolescents have the highest rate of death from drowning. And so anytime, it doesn't matter if it's just less than an inch of water, if there's any water around, those toddlers and those infants can definitely drown from that. So we got to be careful. Oftentimes we'll find that infants drowned in a bathtub. We teach the parent to never leave the child alone. Swimming in undesignated areas and swimming holes, this is usually teenagers, creeks, quarries, rivers. It can be especially hazardous. So just making sure that they're aware of that and taking the proper precautions with that. Treatment when discovered, we will start CPR initially and immediately, continue it until the victim can be transported to a medical facility or have additional care. Intensive care is carried out according to that patient's needs. All right, so that finishes it up. We're good.